patients are undergoing lobectomy. One is undergoing right and the other one is undergoing left surgery. So you can see here the instruments here are all straight, and this is the right side. This patient is undergoing right upper lobectomy. You have to have small, mini thoracotomy to put in multiple instruments, but most importantly the instruments are, the standard instrument that we use, all straight instruments, and anybody who knows about minimal invasive surgery, you know how the chopstick effect is. You can, continuously clash with the equipment. Whereas if you see here on your left side, on your right side, left side, yes, this is, the same operation on the left side being performed using the robot, and you have these special instruments. These instruments are moving inside the body, but the actual movement is, done by me while I am sitting on the console far away from the patient. And because the instruments are very fine, and the versatility of this movement, is the movement is much more than even a normal wrist. So it gives you a much more better way of dissecting important vessels, which is very crucial in patients who undergo lung surgery. You can use this especially Maryland, which is an instrument, robotic instrument, modified instrument. You can use it like a finger. You can go around the vessel, without actually tearing it, and that is not possible with using this kind of straight instruments. So for a surgeon, because of the magnification, because of the 3D image, you can do a very meticulous surgery. Blood loss is much less compared to even open VAT surgery, and there is ease of performing surgery. You are sitting at the console and you have instruments which can move 380 degrees, more than 360 degrees, and you can go around the vessels, important vessels. The only downside, as I told you, is that as a surgeon I am sitting far away from the patient. I am not even scrubbed, and you need to have a very competent assistant who will be with the patient and assisting you in this surgery. Now I am not going to bore you with this entire video because it's at least 7 to 8 minutes long, but I hope you get an idea as to what the difference is. Both are minimal invasive surgeries, but one is robotic surgery, which is, much more hi-fi, one can say, and this is now kind of a standard surgery. So, as time changes and there is progress, you need to keep in touch with the technology and use it best for delivering better results. Now we all know that dinosaurs, they lived for almost 150 million years, but just because they did not change with time, they just became extinct. And as a surgeon, not only as a thoracic surgeon, but as a surgeon and all of us as physicians, we need to be updated with whatever knowledge we have, with whatever technology is there, and if the technology is appropriate and if it can benefit the patients, I think that is something that we should all address. Thank you very much. Are there any questions? Is there time?
Dr. Ashok Gurde to felicitate Dr. Rajesh Mistry. Please accept the felicitation, sir.
Okay.
Sir, be with us for 5 minutes on the dais. This excellent talk by Dr. Rajesh Mistry was sponsored by Kokila Dhirubhai Hospital, and we have Mr. Zubin Dalwala, the Vice President of Marketing, Kokila Dhirubhai Hospital. We call you upon the dais, sir, to accept our felicitations. Dr. Shashank Bhawar will felicitate you. And जैसे दिन निकलता है, prices stakes are getting higher and higher, and now you have fancy things like Android phones and tablets as gifts. So without wasting much time, I call upon Dr. Sushil Sharma to do the honors.
The difference is post lunch, Matka King is going to go to people who are charged. So show that you are charged with your claps. Only bit louder clap. Matka King, Dr. Asif Pochi. Take it.
May I guess? Dr. Manisha Tajune.
Because she was fully charged that time when she received. Okay, over to Snehal, Dr. Snehal.
There's one more lucky draw for this lecture. It is from Amin Pharma. I request Asif Boji. Rohit Thakur will present from Amin Pharma. Dr. Rohit Kapoor, please.
Vagesh R. Yadav. Vagesh Yadav.
Second. Next. अच्छा ये लो.
Dr. Nikhil Khan.
क्या बात है.
Thank you, madam. Thank you very much.
For giving this opportunity to discuss some details about coronary and share some thoughts. What is coronary? Whenever you mention coronary angiography, what we understand is conventional coronary angiography and not CT angio. Because nowadays, since last 4 to 5 years, whenever you say coronary angiography, people sometimes understand it as CT coronary angiography. But here we are going to discuss about invasive coronary angiogram, because it is even now it is the gold standard. 64 slice CT angiogram is comparable to conventional coronary angiography, but since it is not available at many places, second thing it requires a lot of contrast, third thing it involves a lot of radiation also compared to conventional coronary angiography, and interpretation of the CT coronary requires a lot of expertise, expert cardiologist plus radiologist combination or team of many people interpreted. Compared to CT coronary angiogram, conventional coronary angiogram is widely available. It is significantly cheaper, or maybe at par with CT angiography as far as cost is concerned. Third thing is it is very easy to do nowadays, though it is invasive procedure. So, what are the goals of doing coronary angiography? For which patients you are going to do coronary angiogram, and for which patients you will not do. So primary goal of the coronary angiogram is to confirm presence of coronary artery disease or to rule out coronary artery disease. So once you are fully convinced that patient has some symptoms which might probably the symptoms are because of coronary artery disease, in that case you will refer this patient for coronary angiogram. And once coronary angiogram is done, then we will decide what can be done. Are there any lesions, whether to treat it medically or to intervene it. Then if suppose it requires intervention, then what intervention is required? Whether angioplasty will do or bypass will do, or both the options are open, or it is no option coronary artery disease. Sometimes patient has coronary artery disease, but you cannot do any intervention because of some other major disorders or associated comorbidities. So, what are you going to do before doing coronary angiography? So, first thing is clinical examination. As a clinician, you will be looking at the general fitness of the patient, whether he is fit, how is the build. Other diseases like diabetes, hypertension, hypothyroidism, are they under control? If they are controlled, then only you are going to refer it for coronary angiogram. Otherwise, there will be problems after and during the coronary angiography. Then, before doing, though it is the risk of doing coronary angiography is less, but complications are known, though they are less than 1% of the cases. But you will, though because it is invasive procedure, it requires active puncture of the vessel. You will discuss all the possible risk with the patient before doing the procedure. Preferably, we will discuss with the patient how we are going to do it, whether we are going to do it through radial route or femoral route, why we are going to do it like that, and then what are the consequences, how long it will take, and in case of high-risk patients, we will also discuss the risk of complications and possibly prolonged stay in the hospital. Then, after that, the tests which are mandatory is first you will be doing ECG and 2D echo. Both are must before doing coronary angiogram to decide, to risk stratify the patient, whether it's high risk, low risk or normal risk. And few blood investigations are also mandatory. For example, hemoglobin. If suppose hemoglobin is less than 10, we are not going to intervene. That means we are not going to angioplasty. Angiography can be done even at the hemoglobin of 8 or above, but since there is always a risk of bleeding, you will inform the patient that since there is risk, we are going to avoid or postpone till hemoglobin comes up. Then serum creatinine, if it is more than 1.5, you are going to be very cautious, and then using, nowadays everybody uses non-ionic contrast. Previously we used to use ionic contrast also. That was risky for when creatinine is more than 1.5. Suppose the creatinine is more than 2.53, something like that, and then angiogram is must. In that case, you will always discuss with the possibility that creatinine will go up after angiogram, and the patient may require hemodialysis, and you should always involve nephrologist before doing any procedure when the patient has significant kidney disease, and angiogram, doing angiography is must. Then HIV, HBs, anti-HCV is a routine test before any invasive procedure. Chest X is optional in the sense we have to completely sure that chest pain or water pain is there. It is probably cardiac or cardiac origin, and it is not because of any lung infection, pleuritis or pneumonia, something like that. Okay, so if you are reasonably convinced by clinical examination that there is no pulmonary pathology, then even without chest X-ray you can do pulmonary angiogram, but it is better to have chest X-ray in case you are not sure why chest pain, why there is chest pain. Then coming to the indications proper, when patient has asymptomatic or stable angina pectoris, then patient has unstable angina. Angina means when the patient has chest pain suggestive of coronary ischemia, which is typically retrosternal on exertion, which is relieved by either sublingual sorbitate or by resting for some time, and increases on exertion. Sometimes it increases after food, that is called as postprandial angina. And the patient, suppose that angina is not relieved even with chest sublingual sorbitate or basic means, then we may classify it as unstable angina, and that means that patient requires admission. Then those patients who have acetylation and non-acetylation myocardial infarction, they that is doing angiography is must for them to get coronary arteries. Then another which is not very common is post-revascularization.